Stan asked me to talk about how we could make cognitive remediation routinely available. And that's a question of interest because I get an email, I suppose, once a month from a family or a carer somewhere in Sydney, usually, often in New South Wales, saying, where can I get it? What can I do to actually provide cognitive remediation for my relative or myself on occasions? And if you Google cognitive remediation and Sydney or cognitive remediation and providers, and you restrict it to New South Wales or Sydney, or look through, comb through, there are actually very few providers. There are a couple in this room who do provide this for people with psychosis. There are a considerable number of people who provide it for dementia within memory clinics, sometimes for ADHD, but for psychosis, few, very few in this state. Now, Alison said, these are my disclosures. I suppose the particular one of notice for this talk is the fact that I'm the chair of One Door Mental Health, because some of what I'll be talking about pertains to the NGO world, for the not-for-profits. And I think this is an important way that cognitive remediation may well be able to be brought to a broader audience in Australia anyhow. Because we have a number of problems. Our clinical outcomes, not just clinical outcomes for schizophrenia, aren't really as good as we would want them. Cognitive impairments, as many speakers have said today, are an important contribution to that, but this is not recognised by my clinical colleagues. So if I talk to my clinical colleagues, the psychiatrists I work with and mental health team outside the small team that I've indoctrinated over many, many years, the fact is that cognitive assessments are just not done. And unless you know what the issue is, then it's really very hard to think about remediating it. Our systems in this country are very complicated, I've got to say, for the psychosocial treatments, any treatment for mental health, and this is also getting in the way. But I think there are things that we can look forward to improving this. Now, outcome, this is a standard sort of horrible meta-analysis slide, but it underlines the fact that improvement remission is very low. So at the bottom of this is this percentage who've improved, who've remitted, who've not only had symptomatic remission, but they've recovered in that they've had a good psychosocial outcome. This sort of slide has been known to many of you. And in this meta-analysis, around 13.5% met those criteria: good symptomatic recovery and good psychosocial outcome. Many more people had symptomatic recovery, but that full recovery package hasn't happened anywhere near the numbers that you would think should have happened by this stage. And this number hasn't really budged for 50 or 60 years in any meaningful way. It's a small number. I entered psychiatry at the time that early intervention in psychosis was a new movement, and I was very enthusiastic about that. My team was originally an early psychosis team. It's evolved into a youth mental health team. And that also has had difficulty in lifting and improving people's outcome. This particular study is a study from Denmark, the Opus trial, and it had the advantages of working in a well-resourced service that was sealed and was well supported in quite a homogenous community. And you can see that at 2 years, 5 years and 10 years, the little hatched area at the top suggests that somewhere between 14 and 17% had recovery. This again hasn't changed, despite 2 years of good standard early psychosis work. Interestingly, 2/3 of the people did recover at some stage. So they cycled through this area. And I think the future has to be in helping people stick in that recovery area. How can we maximise the way that people can hold on to the recovery, which they often make very well at these early stages of treatment. But it slips away from us. and it's very frustrating for the clinicians. It can be heart-rendering for the individual who usually ends up back in hospital, which is the last place they want to be, thank you very much, and very difficult for the family. But moving this up so that more people are in this top area, and they're not just asymptomatic, so 35% are asymptomatic, but they're not in employment, education, or other useful areas of life. So that is one of the things to try and shift people through. Now, if we just look back to the SHIP data, and it'd be very good if the epidemiological evidence for psychosis could be updated with another such survey of people with mental illness in this country. We can see that 65,000 people met what are called the NDIS, the National Disability Insurance Scheme definition of permanent psychosocial disability, and should be going into NDIS type schemes. Now, as Tony Stevenson and I and many other people in the room would say, that is nowhere near enough people with mental illness difficulty getting into the NDIS. But even the NDIS would recognise that is a significant that group of people should be receiving care. And I think as we go on, and we have perhaps an argument later, this might be one of the ways that we could improve the delivery of something like cognitive remediation. Now, how can you get cognitive remediation in Australia at the moment? So I work in a little team that Alice came out 15 years ago and taught us how to do cognitive remediation, and we've been doing it in one way or another ever since then. So we're in the public mental health services, and many services have done cognitive remediation, still do cognitive remediation, and those services have come and gone frequently in the way that they do this. You could go out to the private sector. There's a very large and well-developed private mental health sector in Australia and receive care in that way. Or you could perhaps go to the NDIS. NDIS, first off. So, complicated and evolving. So these are I suppose one might say these are the rules of today. The rules of today, as we've seen often with the NDIS already, may change. But you can get your money in three buckets. You can get it as a core support, assistance with day-to-day self-care, social participation, being taken to the football, disability accommodation, help with getting good quality disability support accommodation, or transport, being moved backwards and forwards to appointments of one sort or another. You could get it for capital support, and this is the classic NDIS type issue. This is wheelchairs, this is ramps on your stairs, this is changes to your bathroom, this is that sort of thing. Or you could get it in this interestingly large area of capacity building. So that's training in planning, how to figure out, they actually have a category for figuring out how to make your plan, which is paid for. This is how complicated it is. They have to make sure that you're paid to figure out how to organise your plan, or to pay somebody else to do that. Building capacity to participate. So what is rehabilitation or recovery not, if it's not building your capacity to participate in the community around about? It can be help for employment-related advice, exercise advice, behavioural support for behavioural difficulties, life skills, or even lifelong learning. Now, this is a very large and broad category, and although the NDIS won't help with anything with a clinical in front of it, so if you say it's a clinical care or a clinical treatment, you're not going to get it. By thinking about many of the treatments that we've been talking about today, they clearly fall into that capacity building area, and it would be open for that sort of treatment. Now, The other real advantage that the NDIS has, and we'll come back to this, is that it has money. And the money is being paid at a rate which is different to that of Medicare items. Now, the allied health professionals in the area will note that psychologists get paid more than the rest of the allied health staff for NDIS, but it is still at a rate which is considerably higher than the Medicare rebate rates, which we'll go on to talk about. And that's certainly making people interested. There are problems. The system's really inflexible. You have to be able to predict what you're going to be doing for the next 12 months. And that's all determined by a planner that perhaps doesn't really understand your needs. But there is a capacity within this to provide money for reasonable, broad-based psychosocial treatment, which is good because, frankly, in Australia, we haven't had that before. In reality, that bucket of money for capacity building has been smaller because this was a scheme that was developed really for people with physical disability or intellectual disability of one sort or another. So, as we all know in this room, it wasn't developed for people with a mental health issue, and that's a major problem with the whole framing of the program. But slowly, people like MIFA have been sort of using the levers and fulcrums to try and increase the usefulness of this for people with mental illness of one sort or another. Now, all right, NDIS, that's one possibility. What about a private mental health clinician? Now, as I already said, that mostly cognitive remediation is used for ADHD or memory or dementia in primary care. There is some small amount of work in psychosis, but if we look at the top 5 diagnostic categories for ATAPs, for those who aren't, is one of the many small funded areas for allied health services and psychology in particular, you can see that the number of people who were being treated with a psychotic disorder was vanishingly small in comparison to depression or anxiety. And that is one of the problems with these schemes, is that the care that is being provided is not being provided for people with the most severe problems, and is going to people who have mental illness. I'm not disputing that, but it's being weighted away from them. You might also note that the rebate is between $80 and $120 an hour for psychology. That's a big difference. And what does this mean? This means that there's out-of-pocket costs for people, often. And that is also something which goes against people with severe mental illness who haven't got the money for out-of-pocket costs in this particular way. And this, again, shifts the target for these funding programs away from this particular way of funding things through primary health networks or other such issues. I might also add that this plays into another issue which is very important in Australia, and that is that the services that people like me provide happen to be in big cities. They don't happen to be in rural areas, so I take my hat off to our Bloomfield group, Matthew, who are providing this sort of service outside of a metropolitan area. And you can see in these 2 maps of Australia, the top one is face-to-face. The bottom one is services provided by MindSpot. Now, MindSpot is an online internet-based treatment, mostly for anxiety and depression. And it's Commonwealth government funded, and it is increasingly used. And you can see, quite interestingly, that those services are being taken up by quite a substantial proportion of the population in those rural and regional areas. And so there is, as we know, a real need. But I would suggest that when we think about cognitive remediation, we do have to think about the provision of mental health services in a way which recognise the difficulties of living in a big place like Australia, and how can you project these services online if possible. Now, of course, another area you might run into cognitive remediation is a private hospital. But you wouldn't do it in Sydney because we rang up and we asked them, and no, there's no cognitive remediation provided in any private hospital we could find in Sydney. Might be different in other places, but we couldn't find it anywhere. And you might also note that if you have schizophrenia, this is the F20, that's the code for ICD-10, 11, that if you go into hospital, again, it's vanishingly unlikely that you have a diagnosis of schizophrenia. Where you go into hospital if you have schizophrenia is you go into a public health facility of one sort or another. So private hospitals treat people with depression or anxiety, perhaps bipolar disorder. They don't treat people with schizophrenia. And the cognitive remediation, which is a useful treatment, I must say, for people with bipolar disorder as well as major depression, is not being provided because of the mindset, I suppose, of those organisations. Brings us to public mental health systems. Now, this is where I think most cognitive remediation is provided in this country at the moment, for psychosis, I'd say. And I think that Francis's service in Brisbane is an excellent example of that, and is there because Francis has been leading that. However, the services, as I'll go on to talk about, have rarely been sustained. So many services are available in small specialised units, but shifting the mindset of a whole service, a local health district in New South Wales, other forms of organisation, other parts of Australia, has not been successful. And much of this is being driven by at the moment is being driven by the changes brought in by the NDIS and the chestnut that we have in Australia always of the federal-state divide of funding. And with the development of the NDIS, many of the state governments have already pushed many of their responsibilities for community and rehabilitative care onto the NDIS, whether or not those people can get funding for that. And so this is again one of the issues within Australia which makes things complicated. I noted Francis's pie chart which suggested that mental health services are only a small fragment of what somebody needs. Of course, with my one door hat on, I note that even though it might be a small slice of the pie, it's a very large slice of the funding. In fact, it's most of the cake from the point of view of funding. And so mental health, government mental health services from the point of view of government services make up the vast majority of money. And much of this, you can see in this increasing area here, is really government services being run out of general hospitals. And this, I fear, is forcing a concentration on emergency departments and decreasing lengths of stay, which is the enemy of good rehabilitative care in many ways. If we look at NGOs, non-government organisations, there has been an increase in funding, but that is relatively small when looked at the overall bulk of the money that is being provided for mental health cares by government in this country. So, if we're going to think about the implementing of a new program, cognitive remediation being one, and using a model of implementation such as Fixin's one which is quite well known, we think about going from brainstorming, thinking about trying to develop a new program, fixing on the model, preparing the teams for it, having a champion for that, implementing it in a pilot fashion, then moving it out into full implementation to an area health service, using the experience and skills of people there to innovate on that particular program, and then sustaining it in the long term. I'd have to say that I don't think anywhere in Australia has really got beyond the initial implementation, I'm afraid, in realistic sense. So that's, I think the best model for implementation is in Brisbane. Other than that, we are still at the pilot program stage, and I would include my own team in that. So what could we do about that? Well, we do have some of the building blocks of that. Our own local guidelines do, certainly the Royal Australian New Zealand College of Psychiatrists guidelines on treatment of schizophrenia certainly do emphasise that cognitive remediation is a reasonable treatment, and that we should be thinking about doing that. In particular, the synergy of cognitive remediation with other psychosocial treatments is emphasised as something which we should genuinely think about. We've already talked about NDIS funding model as being a possible way of targeting the people with psychosis and their highest needs. But I really would think that we need to look at brain training, internet-based brain training, as a way of reaching a broader number of people and seeing whether that could actually help with this. To bringing it into full operation and integration with other services really needs more, unfortunately, more research and development. I'd note that there are a number of different centres in Australia that are doing ongoing research in Sydney, in Melbourne with Susan Rossell, and in Brisbane. But we really do need that workforce development, that broader integration of cognitive remediation as a treatment in university training, in professional training, and in rehabilitation recovery models. So, what would I suggest? I'd suggest to go where the money is. The money at the moment is NDIS. Certainly, you're much more likely to get therapists to develop those recovery and rehabilitation models, to synergise them together, and to embed the training and supervision in your system. Thank you.